Welcome, everybody. I'm Jeff Borenstein. I have the privilege of serving as the President and CEO of the Brain and Behavior Research Foundation. I'm very excited to serve as the host of this conversation this evening and late afternoon, depending upon where you are. And our guest is I'm on the East Coast, and Dr. Hinshaw is on the West Coast. I'm pleased to serve as the host of this conversation that we've entitled ADHD, What You Need to Know. I'm speaking today with one of the top experts in the field, Dr. Stephen Hinshaw. Dr. Hinshaw is a professor at UC Berkeley and UC San Francisco, and he's also the recipient of the very prestigious BBRF Ruane Prize for Outstanding Achievement in Child and Adolescent Research. Tonight's conversation is geared to teachers, school counselors, other education professionals, as well as to parents and other family members. So let's jump right in. And Steve, thank you for joining us this evening. And I want to start off by having you give us a description of ADHD, its symptoms. What exactly is ADHD?
So ADHD is extreme levels of two facets of behaviors or symptoms. And the first have to do with inattention, distractibility, not following directions. So these are quieter symptoms. The stereotype about ADHD is that it's all about fidgeting, squirming, and running around the classroom. So not following multi-part directions, not seeming to listen, making careless mistakes. These inattentive symptoms, all of us have some degree of them, but if you're at the top of the heap with these symptoms, we would say that you're in the realm of the inattentive form, or what we now call presentation of ADHD. And the other domain is about hyperactivity and impulsivity. So hyperactive impulsive symptoms do include fidgeting, squirming, running when you're not supposed to be running, acting too far ahead of when you're thinking about it, what the consequences would be. And as we'll discuss, those symptoms are somewhat more prominent in boys. The inattentive symptoms are somewhat more prominent in girls, but most kids who get referred have a high degree of both the inattentive and the hyperactive impulsive symptoms. So learning and behavior and classroom deportment are compromised. Kids with ADHD, many people say, well, a lot of young kids. I mean, the terrible twos, most terrible two boys have ADHD. But as you get older and develop better self-control, there are some kids who are really on the far end of the continuum, on the extreme. And those kids who get a diagnosis, and we can talk about what a good diagnosis entails, are way too likely to experience accidental injuries. Young kids with ADHD have a higher risk of death than young kids without ADHD under the age of 6. Failure in school, not necessarily because of a learning disorder, but because of the inability to pay attention and follow directions, et cetera, et cetera. They're way too likely to get picked on, bullied by, rejected by their peers because they may not read facial cues very well, may fight back in ways that make them unpopular. And then later in life, as my group has been involved in several longitudinal studies from childhood through adulthood, these are people who are at risk too often for substance use disorders, for aggression, particularly in boys, and depression, particularly in girls. And as our Berkeley girls with ADHD longitudinal study has shown, far too many girls with low self-esteem and depression get involved relatively early in adolescence in what we call self-harm, non-suicidal self-injury, cutting, burning, self-mutilating, and rates of attempted suicide by late teens, early 20s are much higher than neurotypical comparison girls. Now, many kids with ADHD, with the right conditions and the right settings and finding their right strengths, can thrive later on, but it's a serious condition, even though the stereotypes are, for a long time, it was just fidgety, squirmy boys. Girls really didn't have it. We know now this is an equal opportunity condition. More boys and girls have ADHD, but girls have it. It's across all racial and ethnic groups and all socioeconomic levels.
A very good overview. And I think a key take-home point is this is serious, so it needs to be attended to. what in the classroom, what would teachers see? What should raise the alarm or concern in a teacher? What are they going to see? And it may be different at different ages.
More often in boys than girls, they're going to see, let's start with preschool, running around, can't sit at circle time, poking at other kids, disrupting the story that's being read. Girls, some girls with ADHD at that age are just as disruptive and just as hyperactive, but are more likely to kind of lapse in their attention and not follow what the story is. By grade school, with the academic expectations, these are kids who are often bright. The bell curve of intelligence scores for kids with ADHD follows pretty much the national norms. But if you haven't heard the third part, later in grade school, open your books to page 12, look at the second paragraph and answer question 2. Wait a minute, question 2, what did she say before that? What did he say before that? ADHD involves, as much as these behavioral patterns I'm discussing, problems with a fancy term we call executive functions, maintaining your attention for a long period of time, planning what you're going to do rather than just jumping into it willy-nilly. What we call your working memory, holding a string of information together like the parts of a multi-part direction. Shifting set, we go from math to reading, et cetera, in middle school, from algebra to history, and it's hard to get in the groove of what the new expectations are. ADHD is really misnamed. It's not an attention deficit per se. Many people, kids, teens, adults with ADHD, if they get into engaged in something they really love, it's intrinsically motivating, they can't stop. Video games, preferred activity, where's lunch, where's dinner, where's chores. So if you think of hyperfocus as a symptom, ADHD is more of a regulatory disorder. It's the inability to do well at shifting your gears between when you need to stay focused and still, and then when you're into an engaging activity. And it takes a long time for kids with ADHD to learn those skills. It's called self-regulation, partly because levels of dopamine functioning in their brains, in many cases, don't do the kind of same things that they do in neurotypical brains, which is why what we'll talk about, medications can help, and often, very important for both families and teachers, behavioral reward programs to kind of make up for that gap in intrinsic motivation.
Good. And let's jump into that. I'd like you to start by talking about some of those behavioral interventions,
right,
and then we could talk a little bit about the medicine and the combination of two. But let's start with the behavioral types of treatment.
The evidence-based treatment for kids with ADHD, all the way up to early teen years, mid-teen years, by late teen years and adulthood, we can do more things one-on-one. But the treatments of choice are really engaged in more by parents and teachers than by the kids themselves. Kids with ADHD struggle to get intrinsically motivated because they're not hearing the directions and they're slower to kind of remember the parts of the task they're supposed to do. And their bodies and brains are going to require smaller steps for success and very specific rewards in the early part of their learning to motivate that success. Well, the other kids in the class really don't need a reward chart, or her siblings don't need it. So part of the treatment plan for ADHD is to do some psychoeducation about what ADHD really is. There is a strong biological and genetic component to the spread of behaviors across the ADHD spectrum. But what people can do and get their head around is kids are not willfully lazy or unmotivated. There are some biological differences that produce these behaviors. What we need to do is be very positive. Rome wasn't built in a day. Build behavioral goals and academic goals into small, doable steps. If she isn't sitting at the dinner table the full time and her average, you've used a clock, is 3 minutes, you build it to 5 minutes and then she gets her check on her chart. Or if in reading circle, the boy with ADHD can't last 15 minutes but can last 5, then you move to 7 and then to 9. The small steps build in success. They build a good self-esteem, and they do something that's really important for parents and teachers, which all too commonly, adults working with kids with ADHD or interacting with them, don't do that. You shouldn't be doing that. Get off that wall, do your homework. It's negative and often emotionally pretty loaded. What we try to do is change the ratio from, for every positive, there's 3 or 4 negative comments, just flip it. For every negative comment, there should be 3, 4, or 5 positive comments, which helps if you have a reward program. It helps if you build skills into small steps, and it helps if you stop the bickering and arguing that only lead to more misbehavior.
I think these are very important approaches, and really, in many ways, this part of the treatment is coaching on behalf of professionals who know this,
Yep.
coaching the parents, the teachers, etc., as to what this means and what you should do.
Exactly. And so in a treatment that's called PMT, parent management training, done a lot of places around the country, you learn how to set up a reward chart. You learn how to ignore, for families, some of the mildly irritating behaviors where the kid's just trying to get your goat. You tailor the rewards to the kids improving success at these small steps. Maybe you need a timeout program if a kid's misbehavior is severe, but you still want many more positive interactions and points than negative. You know that if your home chart is in deficit, you're doing it wrong, right? Billy's 10,000 points in the hole. No, you got to have it positive so he's got something to continue to work toward. And then parent management training has big modules on, let's have the meeting with the teacher. And let's have the therapist and the parent or parents and the teacher sit down and figure out what some school goals are. Very behavioral, small steps of improvement from where the child is right now at baseline. And teacher can either electronically or on an index card make a check. Yes, Sarah today did this and that, or no, she didn't live up to that. That report card gets home or it gets pinged over to the parent's cell phone, and those checks are added to the reward chart at home. This puts parents and teachers on the level playing field. They're both working toward parallel goals, and both are reinforcing one another to be positive.
I want to now shift to another type of treatment, which is the medications. Right. And I'd like you to speak about the use of medication to help treat these conditions.
So, medications are more used in the United States than other countries for ADHD, but the rest of the world is gradually catching up. The medications that are the primary treatments for ADHD are called stimulants, which is really a terrible name. Because if you think of being stimulated by medication, well, why would a kid who's already sped up need to be stimulated more? The accurate name is they're SDRIs. Most people have heard of SSRIs, the Prozacs and Paxils of the world. They keep serotonin in the nerve pathway, the synapse, a little bit longer to regulate serotonin. The stimulants are selective dopamine reuptake inhibitors. They keep dopamine in the synapse a little bit longer to help regulate the 5 or so pathways in the brain that carry dopamine as a neurotransmitter. And most of those pathways have to do with executive functions and focus and sustained attention and controlling your motor behavior. The ADHD medications, if you get the right dose, and if you use, there's the methylphenidate Ritalin class, and there's the amphetamine Adderall class, if you will. We can't predict ahead of time who's going to respond to which of those types of stimulant meds, SDRI meds, or what dose. The stimulant meds are in and out of your bloodstream basically in a day and night cycle. So with a good doctor and with a willing teacher, you can fill out some ratings and change the dose once or twice a week over a couple of weeks and find the best dosage. And it doesn't take month after month the way it does for many meds for other psychiatric conditions of kids. There are non-stimulant alternatives which work on the neurotransmitter norepinephrine, sometimes called noradrenaline. They don't work quite as quickly as the SDRIs do, but over several weeks, they can help reduce impulsivity, keep the kid under better behavioral control. They probably, on average, don't have the same attentional boost that you get with the traditional SDRI medications. A lot of families that I've worked with out here in California, maybe it's a skew, say, well, why would you medicate a child for behavior problems? Wouldn't you do therapy with them? Or maybe we'll consider the behavior modification that I talked about before. If you're in doubt, and depending on the severity of the child's behaviors, you can do a trial. And again, the parents and teachers really need to collaborate on this trial so that the daily ratings are done as the teacher doesn't know when the dose is switched, but she fills out the ratings or he fills out the ratings. And you can empirically determine, gee, that low dose of a Ritalin type compound didn't work, but a medium dose of an Adderall type compound worked. And you can prove for yourself. Or there's about 15% of kids with ADHD who don't respond to any form of medication very well. And it would be good to know that too.
I think one of the points that you've made that you and I have discussed is with parents who are hesitant, understandably so, to start their child on medicine, the one way to approach this is to do a trial to see if, does it work? And
That's right.
You're not making a commitment to do it on an ongoing basis, but to just test it out and see what happens.
And we know from the genetics underlying ADHD, genes play a very strong role, but it's not one gene or 20 or 50 or 100. It's many hundreds, if not thousands, operating together. If you do the statistics on this, we find that about 35 to 45% of the biological parents of kids with ADHD have a moderate to severe degree of ADHD themselves, whether they've been diagnosed or know it or not. So a big issue is parenting a kid with ADHD requires a lot of consistency, and you stop that arguing and yelling, what we call coercive behavior patterns, where people are yelling back and forth. But if you as a parent maybe aren't as on top of your checkbook as you should, and maybe you've got some anger management issues, parenting a kid who provides challenges in attention and impulse control is going to be especially challenging. So what we know from good research by one of our colleagues on the East Coast, Andrea Cronus-Toscano, a professor at University of Maryland, is that when you start parents before they start the parent management training, and you help them with their own ADHD symptoms through cognitive behavioral therapy or through medication, or you help parents with their own fairly moderate to severe depression, their engagement in parent management training goes up appreciably, and they do it more reliably and consistently. So ADHD is a family affair, and it's a child, school, parent affair. Everybody needs to work together.
The important point. I want to ask you, for the teachers out there, for the educational professionals, often they're the ones that see this.
That's right.
The parents may see it, but they're the ones who see it and may call in the parents to discuss it.
That's right.
What's the best approach? If you're a teacher and you see these symptoms and you have a concern, what's the best approach in discussing it with the parents?
So I think the best approach is not to be a psychologist, psychiatrist, expert, and know automatically the kid has ADHD, but to have a parent-teacher conference and discuss what you're seeing.
Mm-hmm.
This allows parents to non-defensively say, let's say we're talking about a third grader. Boy, that first grade teacher is pulling his hair out. And the second grade teacher, she seemed to get my kid and went better. And now you're seeing some of the struggles again as the work's getting harder. And parents can non-defensively say in the right atmosphere, I was like that as a kid too. Maybe I never got diagnosed, but you go back and look at my report cards. So you're building some familiarity with the topic. You're building a commitment to work together, and look up in your local mental health center, or maybe the pediatrician your kid has is in a group of developmental behavioral pediatricians with a lot of expertise in ADHD. And if you can get yourself as a family and your school, maybe to have accommodations, the 504 plans or the IDEA plan, so can get into that alphabet soup in a moment, you're going to give your child a fighting chance of not feeling like a failure every year. Even if you talk with kids, and it's never too early, really, maybe preschool years are pretty early, to talk about what ADHD is, and a lot of good doctors do that. But kids say, yeah, but I'm trying just as hard as the kid sitting next to me. Why can't I do it? And you talk about individual differences. Some kids are good artists, and some kids are really good at sports, and some kids can sit really calmly, and other kids need to move around a bit more. Another teaching strategy is not an optimal classroom for kids with ADHD is the old one-room schoolhouse on the prairies. Kids of many different ages, and everybody sits still with their hands folded. Classrooms that are project-based, classrooms that allow some parts of the day where you can stand and work at a workstation and not be sitting, again, with hands folded from 8:30 till 3:30 in the afternoon, may allow some energy to get out and can help maybe kids even without ADHD. Different kids have different learning styles and thrive in different kinds of environments. So interesting research shows that just as in parenting, a combination of warm parenting, parents really love their kids, but really setting limits and controls and sticking to them in this positive reward-based approach. We call this authoritative parenting, is helpful for a lot of kids, but especially for kids with ADHD. In classrooms, what's called a flexible classroom. It's an interesting blend. There are real expectations in the classroom. It's not an open classroom where everyone's working at her or his own pace. But it's not formal, it's more informal in that there are standing periods and that there are periods where kids can work in groups. So structure and some flexibility seem to be, for many kids with ADHD, an ideal combination to get the most out of the native smarts they have. Just as the way that calm, warm, reasonable, democratic parenting, yet with real demands and limits, is probably the optimal approach for families. Easier said than done in both cases.
Right, but important approaches. One other thing that I know you focus on is looking for the child's strengths and interests. And I'd like you to speak a little bit about that as well.
So it's a big question. All parents have some expectations or ideals, boy or girl for our first kid or our next kid, and what they will be when they grow up and what they're going to be good at. And you realize over time, maybe it comes out in preschool, especially for a boy. For a girl, it's going to take longer because she's more likely to have these exclusively inattentive symptoms that may not show up till late in grade school or middle school or even high school. So, and girls tend to get diagnosed later. But parents have this kind of ideal, and then you realize one day, my child has a diagnosis of ADHD, or my teen. I don't know that I called for that. They argue all the time. They can't sit still at the dinner table. Every night's a battle over homework. And that negative focus and the criticism of child, a parent and parent to child, as genetically based as ADHD is, we know from very good data that parents who change their style to a more authoritative stance, warm and limit setting, their kids improve. Biology is not destiny. Same thing for classrooms of kids with ADHD. So one thing I say in writing about ADHD, especially in girls, but also in boys, is you need to radically accept that your kid may not be the kid you expected, or maybe you did because you know about your own ADHD if you haven't. But at the same time, so you can take the blame off yourself. Maybe it was just the genes you passed along. But you also have to radically commit to getting parent management training and getting the teacher involved and doing a medication trial. So it's cutting a little slack. This kid may not be exactly whom I expected. And then, as you noted at the outset, what are they really good at? Maybe it's stamp collecting. Maybe it's animal husbandry. Maybe it's a sport that's not a traditional team sport. If your kid likes something and gets good at it, A, that's a good reward for the reward program you build at home. And B, maybe that's going to foster a somewhat non-traditional career that they're going to thrive at years later. And the strengths approach gets everybody on the positive edge, not the negative edge.
I'd like you to say a few words about the importance of a careful evaluation. You said before it's good for the teacher to call in the parents, have a conversation, not be the one who makes the diagnosis.
That's right.
Okay, you have the conversation, and now you speak to your pediatrician, and they're going to send you to somebody. What are you looking for in that somebody?
Interestingly enough, ADHD takes some real time and effort to evaluate well, but not maybe in the way many of you think. It's a low-tech diagnosis. Sure, there's brain scans now, there's MRIs and fMRIs and SPECTs and all this kind of stuff. That research is progressing. We see some differences in neurotransmission patterns in the brains of kids with ADHD on average compared to neurotypical kids on average. But none of those is good enough yet to say, Jeff, you got ADHD and I don't, or vice versa. What you're looking for is the kids' behavioral and emotional patterns in their everyday world, in that classroom. That's why teacher ratings and a teacher interview are essential. That's why parent ratings and interview are essential. Also with parents, you want to get a good developmental history. What about early milestones? Maybe there's a speech and language delay. Does the child maybe have a subtle seizure disorder? Because seizure disorders can look like ADHD. Has the child been traumatized? Because we know from our own data, jumping ahead to our Berkeley Girls with ADHD longitudinal study, one of the very difficult long-term outcomes for too many girls with ADHD is low self-esteem and depression by adolescence and cutting, self-mutilation around that time, and then actually attempting their own lives by late adolescence, early 20s. That risk goes up by about 300% if a girl with ADHD has also experienced physical or sexual abuse or neglect early in life. ADHD is a really biological thing. We call it a neurodevelopmental disorder. Starts early in life, it's pretty biological, but trauma on top of that, and in our sample, the girls who were and were not traumatized were matched on their level of ADHD symptoms, but the trauma was especially, triggering of terribly low self-esteem and self-destructive behavior later in life. So an evaluation, even of younger kids, I mean, the average girl in our country who starts non-suicidal self-injury, self-harm, starts it now before the age of 11. So we need pediatricians and specialists to screen for depression and to screen for learning disorders and to screen for early self-injury, in addition to getting this deep look at the ADHD symptoms. And then the final part is maybe there'll be some computerized tests of attention, some objective tests. They can be helpful, but they're not definitive. Because one-on-one in front of a computer screen, many kids with ADHD can pull it together for a short while, but then you put them in a classroom or in their family and things fall apart pretty quickly.
And I think another important point in terms of an evaluation and then a treating professional is not just writing a prescription and go home and call, come back in 3 months, but really including the behavioral component really and other interventions. That's what you should be looking for.
And that's what we need to do much more in our country. Yeah. And to close off some of this treatment, I know we're running to the end of our slot here. The research is pretty darn clear. Kids with pretty severe ADHD, moderate to severe, they're clearly in the diagnosable range, on average do best on the right dose of medication with parent management training and teacher consultation and office and social skills help for the kids. It's both together. The medications may resculpt the brain a bit to be more receptive to input, but medications don't teach you academic skills or social skills. You've got to learn them from the behavioral treatments.
Well, on that note, Steve, I'm going to say thank you so much for joining us today. Thank you for all of the research that you've done, for the clinical care that you've done. You've had such an impact for so many people. And as always, I enjoy any conversation with you, and I hope that everybody in our audience enjoyed it just as much as I did and took home really a lot of very important information. So thank you so much.
Well, my pleasure. Always a pleasure to talk with you, Jeff. And thanks everybody out there for tuning in.
Good. Thanks again. Take care, everybody.